let's start with the first one. So a 23-year-old G1P0 at 23 weeks presents for prenatal follow-up. Vitals are unremarkable except for a blood pressure of 145/91. Which of the following is the next best step in management? What do y'all think?
Hey, Tim, I don't think the slide advanced.
It didn't?
Not for us.
Still not?
Mm-mm.
Okay. Anyway, so this first one is 24-hour urine protein collection. So the idea here was basically that she's past 20 weeks. So you know what that means. That's where all the thresholds are for all the hypertensive disorders. And so you need to figure out if it's just hypertension or if there's a preeclampsia going on. So reassurance, you wouldn't do that. A CT is usually not the right choice in a pregnant woman. Surgery, that's way too early for that. And beta HCG is really not really relevant for this sort of thing. So kind of a warm up. So here's a follow-up. So the same question, same person, now the 24-hour urine protein shows 0.3 grams of protein over 24 hours. So what would you say that the most likely diagnosis is out of these 5? Chronic gestational hypertension, preeclampsia, severe features, or normal pregnancy? See, yep. Preeclampsia. How to do. I think my internet must have cut out or something. Let me reshare. Zoom recordings is too much for my Wi-Fi, apparently. Okay. What I may try and do is just only do one screen. Okay, can y'all see again? Okay, so what I was saying is, anyways, you know these pretty much, so just keep it quick. So hypertension is anything before 20 weeks. If they have hypertension, they've probably always had hypertension or have for a while. So that's just chronic hypertension. So you do need to manage it, but it's not exactly the same. They will probably ask you the difference. And then for pregnancy-related hypertension, they use 140/90 still, whereas most people use 130/80. So this is like the only specialty that still uses 140/90. And then there's 2 ways you get to preeclampsia is you either have proteinuria, so you have to remember the numbers, unfortunately. So it's either 300 milligrams, 0.3 grams, whatever unit, 3,000 micrograms, whatever unit they want to use. It's 3 something. And the other way you can get it is end organ dysfunction. And the way that I always remembered it is the end organ dysfunction things are pretty much the same as the severe features. There can be some differences, but if you just remember the severe features, you'll be able to tell if there's end organ dysfunction. So if they don't give you proteinuria, but they give you that some other organ is malfunctioning, you can definitely pick preeclampsia and feel safe about that. So I don't know if y'all knew the severe features. These are, what's up?
There was something when we were on the wards about like bun creatinine ratio. With that too, that's also like greater than 0.3, the ratio. Yep. Is that the same thing as the proteinuria, or are those just 2 different?
Those are 2 different things. That's a good question. I didn't put that in here so it wasn't complicated, but yes, that's another way. So the third way that you just said is if BUN creatinine is 0.3. So it just happens to also be 0.3, but that's different than, so this is the amount of protein. That would just be the ratio of BUN to creatinine, but yeah, good point. And then those are the severe features. To me, normal people shouldn't have any of those 5 things, so they're pretty easy to remember. The exact numbers are kind of hard, but if you think about it, 150 to 150 of platelets is pretty normal. So until you get below that, it's not abnormal. And then those are also like the blood pressure thresholds. Those are also they're close to the thresholds for hypertensive urgency. Kind of, it's hard to remember. I don't have an easy way, so you almost just kind of have to know it. And then other info here. So what would you do? You may have seen this in UWise. What would you do if a patient previously had preeclampsia and now has another pregnancy? Is there something you would use to treat that, even though she hasn't been diagnosed yet?
Aspirin.
Yep. I've seen that tested many times, so good. Low dose aspirin, so that's just the 81 milligrams, and you can do it 12 weeks through the whole pregnancy. And then what would you do in the same scenario, but instead of treating it, what would you, or preventing it, I should say, what would you do to screen? Is there something you could do to screen to see if she's at risk?
Are the baseline labs also just like a 24-hour urine collection?
That's right. Yeah, so it's not something I've thought about a whole lot, but it makes sense, right? If somebody has a baseline urine protein, then you can see how much that increases over the pregnancy and determine if preeclampsia is happening or if that's just where they've been at since, because people can have underlying conditions or previous kidney damage from diabetes, things like that. So I think that's the purpose of that. And then treatment is pretty straightforward. If they give you one of the first two, hypertensives or magnesium sulfate, you can usually pick them, but usually what they want you to know is when you deliver. So it's hard to remember because OB is all about thresholds, but typically with preeclampsia, you're safe to deliver at 37 weeks. Unless there's severe features, then it's 34 weeks. And that's confusing but important because other conditions you deliver at different weeks. So we'll talk about those later. But those are the main thresholds to know. So main things are know which disorder is which, know how you can treat and screen, and then know what to treat and when to deliver. But since you guys know this pretty well and have covered it, I won't spend a whole lot of time on this. And if you have any questions, just pop in. You don't have to wait. Okay, next one. So 30 or 25-year-old G2P1 at 32 weeks presents for prenatal follow-up. And so her fetus is in transverse lie. Which of the following is the best next step in management? Expected management, external cephalic version, internal cephalic version, expedited delivery, or C-section?
Is it A?
Yep, that's good. I meant that to be tricky because you basically just have to know exactly when you do what things to get that right. Good. So this is how I remembered this. I remember thinking it was confusing, and then I realized you do the same thing until certain weeks. So between 0 and 37, the vast majority convert. So if they'll trick you and throw in breech or transverse lie or single footling, they'll give you any type of presentation, but it doesn't really matter because they could be completely upside down and sideways, but in reality, by 37 weeks, they should convert back. Babies move throughout the course of their maturation process, so that's not abnormal. So you don't need to do anything really ever until 37 weeks. So you can pick expectant or reassurance or no treatment until 37 weeks. Then very specific scenarios at 37 weeks, you can do external cephalic versions. That's just the hand on the belly. I've never personally seen internal cephalic version ever be right. I think there may have been a UWIS question where it was right before, but I've never seen it be right on a real test. That could change if you've seen scenarios where it has been true. Don't feel like I'm the absolute on that. And so the scenarios where you would be 37 weeks, but would not do external cephalic version is one, if you failed it, because then you would potentially harm the baby or tear the uterus or something if you tried it again. So you don't try it more than once. If they're ever in active labor, that's a contraindication. So active labor at 37 weeks or active labor at any other time, you wouldn't do it because there's the risk, because the baby could already be presenting and there's the risk that you damage some sort of body part depending on how they presented. And then, or if there's any normal contraindication to vaginal delivery. So the normal things like non-reassuring fetal heart tones, persistent variables or lates, things like that. The things that you would normally do a C-section for, you still do a C-section for. But the important thing is that if they're at 37 weeks and they're not in the typical cephalic presentation, you can't deliver them vaginally in the US. They just don't. And that's how they test it on shelves, is they don't want you to pick vaginal delivery. So important contraindications for external cephalic version. So like I just said, any indication for a C-section. If there's any type of abnormal placenta, you also don't do it then, just like you wouldn't do a vaginal delivery for those conditions either. There's the risk of hemorrhaging through the placenta. And then multiple gestation, because if one fetus could be in a normal presentation, the other could not be. And so typically you don't want to mess around with that and risk injuring one or two of the infants. And then ruptured membranes, because basically once the membranes rupture, you try not to do anything with your hands as best as possible. I just think that the membrane, like the amnion, is sort of just this protective sac. And so anytime that that's broken, you basically disrupted the barrier and you basically don't do anything at that point. Okay, no questions, we'll move on. Next one, a G3P2 female at 35 weeks presents after noticing a gush of fluid this morning. Nitrazine and Fern tests of the fluid are positive. Which of the following is the best next step in management? These are purposely vague. Shelf questions can either be way too short or way too long. Expectant management, antibiotics and steroids, mag sulfate, delivery or C-section. What'd you say, E?
The second one.
Tricky. I made it tricky on purpose. The one I chose, I made the answer on this one was D. And I'll show why. It goes back to the weeks thing again. I don't know if all of you were going to say that or say something different, but it goes back to the weeks thing again. So
is it 34 that you would do antibiotics?
You would still do antibiotics, yes, but you do need to deliver at 34 as well. So antibiotics and steroids would be, I'll show you in a second, would be what you do before 34. Yeah, that's OB. So here I tried to make it as simple as possible. Here, oh my gosh, I can't move the faces properly. Anyway, so preterm is before 37 weeks, premature is before the onset of contractions. And so the thresholds that are important to remember is that before 34 weeks, you're safe to throw in steroids as an answer in the answer. Before 34 weeks, it promotes fetal lung maturity, but after 34, it's the risks outweigh the benefits, I think, is why you don't go with it as much after 34. And then, as you know, anytime before 32 weeks, you throw in mag sulfate because it's neuroprotective. And then once you hit 34 weeks, you do need to deliver. So it's different than preeclampsia, because normal preeclampsia with no severe features, you can wait till 37 weeks. Whereas PPROM, they want you to deliver at 34 weeks if there's no problems. So then at the bottom is management. So management is just putting together the thresholds into, if you just want to memorize it this way or remember it this way. So if you're less than 32 weeks and there's no infection or compromise, you do three things. You do mag sulfate, steroids, and antibiotics. Basically, all of the groups get antibiotics. So that's not one you have to worry about too much. Then if it's if it's between 32 and 34 weeks, you get rid of the mag sulfate because it's not really neuroprotective anymore, but you still do steroids and antibiotics. Then the tricky part is if they seem unstable at all, whether that's an infection like chorio, or they're compromised, like there's some sort of fetal heart tracing that they're giving you hints that they're not stable, then you want to deliver even if it's before 34 weeks. But you still do the normal before 34 week stuff. You do steroids, you do antibiotics, and if it's less than 32, you do magnesium. So this can be infinitely confusing because it can be 33 weeks, then they can be stable or unstable, and then you just have to keep all of this straight. So it's best to just have these cutoffs in your head where, okay, it's before 34, so I would rather not deliver unless they're making me say that they're unstable enough to deliver, and you kind of just think through it like that. But then at 34 weeks, typically you deliver, and you can also still do antibiotics. Does that make sense? Is that what you guys have learned to this point?
I have a quick question, because
Sure.
I think I'm confusing this with just preterm labor. So with preterm labor, is that where you do tocolytics before 34 weeks, magnesium before 32, and then steroids before 37? And that's different than PPROM?
I believe so. I'm not sure. So I was going to add it in here and I didn't, so it didn't get bogged. I thought steroids were still 34. I could be wrong about that. Okay, now we'll move on. This is all the stuff that I thought was super high yield, and then I created these mind maps, I guess, for how you differentiate them. So this is just all something I created. So if you find that something you've used that's different has worked for you, you should totally stick with that. This just helped me. So this is just, you guys can just shout out whatever comes to mind. So when you think of postpartum dyspnea, is there anything that comes to mind? And again, this is like a read my mind thing. I made a couple of things, but you guys, I'm sure will have plenty of great ideas that aren't on this list necessarily. It didn't fit in this like I picked the things that very much perfectly fit in these like grouping kind of categories sort of thing. So anything come to mind?
PE.
Yep.
Oh yeah, I was kind of gonna say the same thing, but like amniotic fluid embolism.
Yep. Those are the two. You got it. That's exactly what I was going for. So this is what I figured out because I initially was like, how in the world can I tell if it's the difference between these two things? And I realized, and I started using this sort of formula, and I don't think I missed another question on it after I started doing it this way. So the biggest thing is the timing. So the way they present amniotic fluid embolism every time is they just gave birth and then they have shortness of breath. Whereas for some reason, they like to give you a little bit of a delay with PE. So they'll say she delivered yesterday or last night or 2 days ago, and now she's all of a sudden short of breath. And I think the reason they do that is just because the amniotic fluid, whenever you deliver, obviously the placenta detaches. So that's the perfect chance for a clot to dislodge from the placenta. Whereas a PE, all of pregnancy is a hypercoagulable state. So there's not like labor itself was the problem. They were always, I mean, labor increases the state, obviously, but they were previously in a hypercoagulable state. So I think that's how I rationalized to myself the delay there. And then the other thing, which you all have probably noticed by now, is they love to throw in DIC symptoms as a hint for amniotic fluid embolism. So if you ever see that, I would definitely pick amniotic fluid embolism over PE. But if they don't give you DIC, or if you just want something else to help, I think the timing is the biggest thing. Does that make sense? Okay. I tried to keep it relatively simple. I 100% I saw that on my shelf, so hopefully that's free questions for you. That's the idea. Okay, moving on. Genital ulcers. Remember the talk in second year, and then I guess the UWorld chart and stuff like that. Y'all remember some of the causes?
HSV.
Mm-hmm.
Syphilis.
Mm-hmm.
Chancroid.
Yep. Any others? We'll get to them. If not, I know you probably know them all.
Does the chlamydia one, lympho, whatever, yeah.
Yep, the one nobody can say, but you see it. Yeah.
Mm-hmm.
Cool. Yep, that's most of them. So here they are. So here's I think most people use this way to split it up. Painful and painless. So there's 2 that are painful and there's 3 that are painless. So we'll start with the painful ones and figure out how to split those up. So if you're given 5 choices and they say it's painful, you can just cross out the other 3. So now it's like, how do you pick between these 2? So herpes will always give you some sort of buzzword. And on step 1, it was an ulcer or vesicles. But for some reason on the shelf exams in that's step 2, that's too easy. So they stopped doing the ulcers. So I didn't bold that. So now what they say is multiple or grouped, specifically grouped. If they say grouped, and then if they say grouped ulcers or something on an erythematous base, those are probably the ones in quotes are probably the 2 biggest buzzwords that I see these days because it's not as well like thought through as ulcers as everybody thinks of ulcers and thinks of like, or like if they say small vesicles, everybody thinks of herpes. So that's how I would decide if it's herpes. And then the way I would decide if it's a chancroid is if the ulcers themselves, so chancroid is like the worst kind to me, like based on the symptoms. I've obviously never seen it because it's really rare, but basically the ulcers are severely painful and they'll say there's some sort of exudate or friable base. It's basically like they're leaking fluid because they're so filled with fluid. And then the lymphadenopathy is very severe and it also undergoes pus leakage. So it's like actually leaking fluid. So I didn't put it up there, but herpes, I think, can have lymphadenopathy. But if it says anything about friable base with exudate or the lymphadenopathy is leaking pus, that's when I would definitely go with chancroid, even if there is lymphadenopathy and HSV. Hopefully that makes sense. And then, so now let's move on to the painless ones. So I bolded the stuff that I thought was useful for differentiating these. So syphilis usually is just plain and simple, just one chancre. That's pretty much what it is every time. They usually don't give you any lymphadenopathy, but it's single, whereas granuloma inguinal or the Klebsiella one is multiple. So if you want to just, you almost have to split them up into twos here. So primary syphilis and granuloma inguinal, I would differentiate based on whether there's a single ulcer or chancre and versus multiple. And then the two ones that have granuloma in the name, the Klebsiella variety doesn't have inguinal lymphadenopathy, whereas the lymphogranuloma venereum, the chlamydia version, does have large lymphadenopathy, and it's usually painful. I think it progresses over time is what UWorld says. So if you split it painful and then painless, and then for painful, the descriptions will be very different. And then honestly, in chancroid, they might even give you a history of something like they immigrated from somewhere, or they like something abnormal, because it's not a super common thing, whereas HSV is very common. And then syphilis is a single, granuloma inguinal is multiple, and then LGV is, the ulcers themselves are painless, but they can have painful, and they probably will have some sort of inguinal lymphadenopathy. That sound good? Okay. Postpartum hemorrhage.
Uterine atony.
Yep. Yeah, however you say it, that's probably the number one thing people think of. Then there's the mnemonic, I'm sure we've all used at some point in our lives. I don't know if it's a mnemonic or more of just like a phrase. Sorry, Carly, were you going to say something?
You're good. I forgot the phrase, but I know it's like coagulopathy, retained products of conception.
Yep. Yeah, I have it on this slide, so no worries. So it's the T's, the 4 T's, and then all the other things. So tone, trauma, tissue, and thrombin. So this one is probably just as much as the last one. It's important to pick out the quotes or the little hints that they're throwing you in the question, because they love to be vague about these. So the first one is atony, like you said. That's the most common cause by far. And so if they don't give you any information or hints, they just say someone presents for postpartum bleeding, and they expect you to assume it's something. That's what I would assume that it was. I would pick that. But usually they'll give you a hint. They'll say it's soft or boggy, meaning that if you palpate the uterus, like I'm sure you guys did on L&D, that you should be able to feel it firm. It should contract after birth. Trauma is kind of a hard one. So if you've seen any delivery of larger infants, you might have seen this, but the uterus might be firmly palpated in the question because nothing is wrong with the uterus. That's kind of a hint that it's not atony, like we just talked about. And then look for other hints, like if the infant was like 10 pounds, if they're giving you a huge hint like that, like the infant was just a very big, that's probably a hint. Or if the delivery was like extremely long, like hours and hours and hours, there's the potential that all the pushing and stuff created a laceration. I rarely see that, because it's hard to test. It's a laceration, and they give you laceration in the question stem. That'd be way too easy. So they usually won't say that, unfortunately. You have to just look for hints. And then the tissue part is just anything wrong with the placenta, whether that's retained tissue or abnormal placentation, like placenta previa. But what they like to say is some sort of hint related to when they delivered the placenta, right? Because they deliver the baby, then they deliver the placenta. And so you look at the placenta after you deliver it. And so they'll say it was incomplete, or the ultrasound showed that there's some placenta left in the uterus, or it's fragmented, or it's just irregularly shaped. Something will give you a hint that the placenta isn't fully delivered, and that tells you that some of it is left over, and that's probably what's causing the bleeding. Thrombin, the coagulopathy, is less common, but if they're going to give it to you, they'll give you some family history or previous bleeding. So like someone who bled heavily with their menses. And then the other thing is that usually it's delayed, because usually, and von Willebrand's not a great example, but usually the inherited causes of coagulopathy are secondary, like the coagulation cascade. So the platelets work fine and they initially stop the bleeding, but then later on when you need thrombin and things to connect the clot, it doesn't, and so it rebleeds later, kind of like hemophilia versus von Willebrand's. And then the other one is that doesn't fit in the 4Ts is uterine inversion. So that one you've seen a million times. That's the one where the uterus actually protrudes outside of the vagina. So there won't be a uterus palpable at all. It won't be foggy or soft. It'll be just gone. And then they might say there's a smooth mass protruding from the vagina. And that's the one where you probably need to know the resuscitation measures. I didn't put it in here because this slide was already busy enough, but you basically place 2 IVs, you manually replace the uterus, and then you can figure everything else out afterwards, like uterotonics and stuff like that. So you definitely want to replace the uterus ASAP before you do other things, because that's going to be the cause of bleeding. And if you try and do all these other measures first, you're basically reducing the likelihood that the uterus will reposition properly. There's a lot more detail on that, I remember, from whenever I was doing them, but I didn't spend time making enough stuff on it here. But I'm sure y'all have covered it. Okay, I know Dr. Henning does one of her weekly sessions on this. What do you guys remember about 3rd trimester bleeding? Or I should say causes.
Placenta.
Yeah, most of them are related to the placenta. Yep. So it's kind of like the ulcers. I just do painful and painless. So, man, I can't ever get these pictures in the right spot. Golly. Anyway, so yeah, so painless, it can either be placenta previa, vasa previa, or vasa previa, however you say that, and then bloody show. Although I've never seen that be right on a UWorld like board style question. It was in UWise, but I think it's worth knowing that some measure of blood can be normal. But super high yield, that the only way you really distinguish placenta previa and vasa previa is if the baby is unstable or bradycardic. And that's because, I wish I'd put a picture here, but placenta previa, the bleeding is coming from the maternal side. So if this is the inside of the uterus and the placenta is here, the side that's sticking out of the cervical os is the maternal side, the side facing the uterus. So that's maternal blood that's leaking out. So the baby wouldn't be bradycardic because the baby is not bleeding, the mom side is bleeding. Whereas the vasa previa, if you think about the cord, it inserts into the placenta on the fetal side. So if the cord is inserting this way and it bleeds, that the baby is bleeding and the mom is not bleeding. And so, I mean, technically the mom is bleeding because it's connected to her, but the baby becomes bradycardic because it's losing blood. So they'll give you the same thing, painless bleeding, and you look at the fetal heart rate. And if it's normal, pick placenta previa. And if the fetal heart rate or something about the fetus is abnormal, you can pick vasa previa. And then if for whatever reason, the blood, they give you some hint that the blood is normal sounding, or they say small amounts of blood or minimal mucus or something like that, and the placenta is normal, then you could probably pick normal pregnancy or normal labor or something like that. That'd be really tricky if they did that on the shelf, but they probably could do it. And then placental abruption. So these are the two, and uterine rupture are the two painful kinds. So the difference between them is abruption, basically the placenta separates from the uterine wall, but oftentimes it's trapped, and so the blood is retained in this small space, and so it's extremely painful, as you can imagine, for the placenta to rupture mid-pregnancy like that. And one thing that's different about abruption versus rupture is the placental abruption leads to high frequency contractions or high tone, whereas uterine rupture, as you can imagine, if the uterine wall is a connection of muscle fibers and it ruptures, you lose the contractions. So it's the exact opposite. So the buzzwords with uterine rupture, well, first risk factors. So the risk factors are different. So vertical C-section, so the traditional C-section, or uterine surgery, like removal of fibroids, both of those, any surgery that actually opens up the uterine wall is a risk, like vertically, is a risk factor for uterine rupture, because the uterine fibers run circular And so if you interrupt it perpendicular to the muscles, they don't have a chance to reattach properly. Whereas if you do the low transverse C-section, you're basically opening up the fibers in the length that they're already set up. So you're not disrupting the actual ability to contract. So the buzzwords: irregular mass, if the fetus protrudes through the wall, loss of contractions instead of high frequency contractions, and then loss of fetal station. They won't say loss of fetal station. They'll say 4 hours ago, the baby was at 0. And then now they're at -1. And if you're not looking carefully enough, you'll think that's just normal. And you'll think, oh, it's like 0 to 1. It seems normal, but be careful of what the numbers that they give you. They'll give you a hint like that. It'll be kind of subtle.
Hey, Tim.
Yeah.
Where would like placenta accreta or percreta fit in? Would that be with postpartum hemorrhage mostly, or?
I think because if you think about it, most of those, the placenta is attached very strongly to the uterus. So the only time that it would bleed is if you're manually trying to remove it. So it really typically, to my knowledge, that doesn't bleed prepartum. It usually bleeds postpartum. Whereas the placenta is detaching or rupturing not by the provider's cause, it's just by the nature of the placenta formation. So it happens before or during labor. Okay. Vaginal infections. These are relatively easy. Just wanted to make sure we covered these. So I split it up into discharge, pH, and then other hints, and then treatment. So Candida, if you think about it, it's a fungus, and it's the obvious white, thick cottage cheese discharge. Bacterial vaginosis is the off-white, fishy odor kind of discharge. Trichomonas is the green, frothy discharge. So if you see any one of those, you could pick it and be safe, and you could get the question right. If you see white discharge, pick Candida. If you see off-white, you can pick, well, you probably won't describe it like that, but they'll say like fishy or something, you pick bacterial vaginosis. And then if you see green discharge, you can pick Trichomonas. And then the pH. So the only one that's normal, it's best to just remember the one that's abnormal or the one that's different, I guess. The only one that's normal is Candida. pH is less than 4.5. The other two have abnormal pH. And then bacterial vaginosis or Gardnerella is the only one without inflammation. The other two have inflammation. And then unique features, BV has clue cells. That's the bacteria are adhering to the epithelial cells. There's the criteria for BV that I think y'all had to cover on the OB rotation. And I think you have to have 2 out of the 4 of the odor, the discharge, the pH, and then the clue cells for bacterial vaginosis. And then the strawberry cervix is another hint they'll give you if they don't give you the green discharge for Trichomonas. So if they say the red spots on the cervix or punctate hemorrhages or petechiae or anything that suggests that there's bleeding on the cervical portion of the uterus, you could pick Trichomonas. And then treatment makes sense. Treat with an antifungal for Candida. The trick though is if they're pregnant and you want to treat it, you typically don't use the oral versions because they affect CYP450. And so I think that typically I've actually seen them use it anyways, but on UWorld, I've seen them test to use like the topical variety. So the intravaginal, like clotrimazole or miconazole, you can use those too. And then the difference between BV and Trichomonas is that Trichomonas, you treat both the partner and the patient, whereas bacterial vaginosis, you just treat the patient. And then don't forget that clindamycin can be used to treat BV. So the ways they'll make this tricky is, because it's so often tested, is they'll give you BV, but they won't put metronidazole as an answer. So then pick clindamycin because they both cover anaerobes, right? And anaerobes are what are causing this problem in the first place. And then the other thing is they might put D and E as one is metronidazole and then one is metronidazole for the patient and the partner. And they're basically wanting you to know which one you use for which. So not hard. BV is not an STI. It's just a pH and a dysregulation of the bacterial flora, whereas Trichomonas is an actual sexually transmitted infection. So you need to treat both. Otherwise, the partner that gets treated will constantly get it from the partner previously. Relatively simple. This is probably the highest yield slide here, so I made sure to make a point of this. I don't know if they've told you, but I personally got between 6 to 8 different benign breast disorders on my shelf. So this is also true for IM, so I think it's good to cover it, or surgery, sorry. They put breast disorders on like every exam in 3rd year, unfortunately. So what things do you think of when you think of benign breast disorders?
I just want to say that's funny because we had 0 breast questions on our reproductive final. But benign breast, like fibrocystic changes, fat necrosis.
Yep. All good things. Okay, we'll move on. This slide is super busy. So I'll try and split it up in like a logical way. So I split it up into the pregnancy related ones and the non-pregnancy related ones. I think that's the easiest way. So let's start with the top since it just makes sense to go that way. So let's do fibroadenoma versus breast cyst. This is, I think they removed the question in UWorld on this. But the thing is that I saw this on my shelf. And so if I hadn't have seen the old version of the UWorld, because the shelf questions are old questions, right? So they haven't removed the shelf question for it. So the way you tell between a fibroadenoma and a breast cyst is fibroadenomas are firm, breast cysts are soft, and then fibroadenomas are more common in younger than 30-year-olds, and breast cysts are more common in older than 30-year-olds. So if you see soft over 30, pick breast cyst. And if you see firm less than 30, pick fibroadenoma. And then fibro or fat necrosis is tricky because it almost looks like breast cancer in a young person. It'll be this irregular mass with skin retraction. They'll almost never give you trauma, but I put it on there just because that's how it happens. Just people don't remember it. And like ecchymosis, it sounds really bad. And you're like, wow, this person has cancer. And then they'll give you the biopsy maybe, and it'll say fat cells and macrophages. And you're like, okay, that's not malignant. That's just fat necrosis. So that's another one that can happen. So that's not one you have to differentiate from these other ones. That's just something you need to know that's not malignancy, basically. And then fibrocystic change, like you said. So this is out of the ones we've talked about so far, it's the only one that's usually multiple and bilateral. All the other ones are unilateral and singular. So it'll be like irregular breast contour or a nodular breast, like breast, or palpable cords palpated through the breast, something like that, that's saying that the breast is irregular because there's a bunch of these masses. And so this and fibroadenoma are the ones that vary with menses. And so they almost always want you to do a menstrual diary or come back after menses and see if it's gone away. Because if it's gone away, then you know it's probably this and you don't need to do a whole lot for it. So I definitely saw breast cyst, and I think I saw fibroadenoma on my shelf. And then these next 4, I think I saw all 4 of them. So I'll go through these 4. So breast engorgement, out of these postpartum related ones, so these are all pregnancy related things, right? Pregnancy / postpartum. So the only one, just like up top, there was only one that's bilateral. Breast engorgement is the only one that's bilateral. Basically, the mom is making milk after just giving birth. And so both the breasts are enlarged. And if the milk hasn't started to be excreted yet, there can be enlarged breasts. They can be warmth and some tenderness, but they won't have a fever. So they should not have a fever. A patient should not have a fever with breast engorgement. And then hopefully that makes sense. That's going to be very different than the other ones we'll talk about. So then galactocele. So that's basically the same thing as a breast cyst. The only difference in my mind is that a galactocele is a breast cyst full of milk instead of just cystic fluid. So I think that's the only difference there. Basically, the breast, the lobule and the duct gets blocked, so all the milk pools into one loculated kind of ball, and so it feels like a cyst. It's unilateral and it's subareolar, right? Because that's where the milk is coming out, is right through where the nipple area is. So it'll be usually, not always, but usually be subareolar. But because it's not an infection or not a, I mean, it's pathologic, but it's not an infection, so there will also be no fever. So if you think of that as just being a breast cyst in a pregnant person, that'll be a lot easier. And then mastitis, that one's pretty easy. So it looks like cellulitis of the breast. There'll be erythema. It's the only one so far with erythema of the skin. There'll be tenderness, and then there will be fever. So far there's only 2 things on this list with fever thus far. So acute mastitis is one of them. And then breast abscess is the last one. So breast abscess is the same symptoms as mastitis. The only difference is that the infection has collected as an abscess. So it'll be called a fluctuant mass. So that's the only thing you ever need to know to differentiate that from mastitis. Mastitis is just a local infection, and a breast abscess is once it's collected together into an abscess and formed like basically a pool that can't escape itself. And then this slide is super busy, so sorry to give you one more thing to remember, but there's also inflammatory breast cancer. And so that's another one that can cause fever, unfortunately, and it looks different though, right? So it'll say the breast is edematous like throughout. It won't be like a localized thing. It'll be edematous throughout. It'll probably be unilateral. There will probably be some lymph nodes, right? Because breast cancer spreads through the lymph. And then they'll probably say something about the skin is pitting. So there'll be like the dimple looking appearance, the orange peel appearance. So that's probably the hint they'll give you for that. I apologize for not putting that on the slides. And since that's super high yield, do you have any questions? Does that make sense? How to split those up? It's not hard. I just feel like nobody covers it. So it's just a matter of knowing which one is which. Fever, unilateral, bilateral, location, and then masses, basically. Okay. Moving pretty quickly. Okay. So acute ovarian related abdominal pain in a healthy young female. As you can see, I'm being very specific. So does anything come to mind?
It's just ovulation.
That's a good one.
Ovarian torsion, since it's acute.
Yep. I should have put ovulation on here, but good one, Carly. That's also good. There's one more I was thinking, but we'll just get to it on the next slide. So the two I put here, is that what you were going to say? Yeah. So the two I put here are the ones that I felt like, again, these are all, the reason I put these in here is because you have to distinguish between them all the time. So ovarian torsion, right? So the ovary twists on the two different ligaments, the suspensory ligament and then the uterine ligament, or the ovarian ligament, I think. So it's just twist between those. And so that's what's happening there. A ruptured ovarian cyst is exactly what it sounds like. So the question is how do you tell these two apart? So I don't have something super cut and dry for ovarian torsion because it looks so similar. But if they ever say that there's been previous episodes like, oh, I've been getting these random spikes of abdominal pain and they've just gone away, and then all of a sudden she's got this acute abdomen and it looks like it's related to the ovary, that's probably good enough to pick torsion. They won't always give you that, but that's something I would definitely consider. And one thing I remember is that, and so we'll jump down to ovarian cyst real quick. So ovarian cysts, unique features are peritoneal stuff. So, and the reason being, if you're leaking fluid out of the ovary, right, and there's a bunch of free fluid in your abdomen, I don't know if any of you have had surgery yet, but generally when fluid is leaking out of a viscera into the abdomen, it causes all of the peritoneal signs because it's basically directly irritating the peritoneum from the inside. So anytime there's free fluid in the abdomen, you'll have the typical rebound, guarding, and rigidity, the peritoneal signs. Whereas also the other one I would say is important is hemodynamic instability. And the reason being, if you think about the ovary as a reservoir of fluid, and if you rupture it and it's severe enough that it doesn't repair itself and you keep leaking, because the ovary is connected to vessels, right? So there's technically blood flow to the ovary. And if you just constantly leak fluid out of the ovary, over time, you'll just leak more and more and more. And theoretically, you could get hypovolemic. In reality, in real life, that's probably never going to happen, but it's possible. And I think that's another way you could distinguish the two. So those first ones are how I would differentiate them if you weren't given any ultrasound, which would be really hard, but that's the best that I've got. And then the easy way is if they give you an ultrasound, and then it's pretty cut and dry. So ovarian torsion will have decreased Doppler flow. The vessels are basically strangulated, so there's no flow getting to the ovaries. But the ovary itself will be enlarged and edematous, and that's because the veins aren't draining it as well. So you're not getting any blood flow in, so it's ischemic, but you're also not getting any blood flow out, so it's enlarged. It's kind of the same thing as testicular torsion. Obviously, it's just intra-abdominal, so it's harder to distinguish. And then ultrasound is kind of the same thing as before. A ruptured cyst is going to leak fluid. So free fluid is how you would tell the difference on ultrasound. So you can tell clinically, although it's harder, and then you can tell via ultrasound and it's more cut and dry. Okay, I think this is the last one of these before we move on to the rapid review. So oligo and polyhydramnios. You guys want to just shout out some causes, then I'll go through these quickly. There'll probably only be maybe 1 or 2 questions on this, not a lot.
Renal agenesis or like Potter sequence.
Down syndrome? Question mark? Is that?
Probably could. I didn't put that on the list. I think, oh yeah, actually I think there is something that it can cause that could potentially be, yeah.
Duodenal atresia.
Yep. Yeah, so I think it can cause duodenal atresia, which can cause polyhydramnios. So the important thing, I think, for the OB shelf is to know the numbers. So this is another numbers game. So normal ranges for so AFI is amniotic fluid index. So the index 5 to 24 is normal. So less than that is too little, more than that is too much. And if they don't give you that, they can also give you the single deepest pocket, which is basically when you look at the ultrasound, the deepest pocket of fluid that you're able to see. That's either 2 to 8 is normal. So less than 2 is too little, and more than 8 is too much. So that's the first step, is knowing the numbers, because they're not going to tell you polyhydramnios or oligohydramnios. They'll tell you the number and they'll expect you to know it. And then the question is, so clinically, what do you see? So polyhydramnios, the main thing is just the enlarged uterus. You may get something more obvious like increased fluid, but I just don't see them doing that. Whereas oligohydramnios, it'll be a uterus less than estimated dates. And like you said, Potter sequence, so pulmonary hypoplasia, flattened face, dysmorphic limbs. Basically, if you think about a uterus holding a baby with like a bag of fluid, essentially, that if you reduce the amount of fluid, the baby is just constantly rattling around. And so there's no room to, and you're basically getting smashed around. So the face is flattened, the ears will be short, the arms will be the limbs will be dysmorphic. And then because you need to breathe the amniotic fluid to develop your lungs, there will also be pulmonary hypoplasia. So that's what Potter sequence is. Although I think technically Potter sequence starts with the renal sequence. So if you look at so we'll go to causes now. So we'll start with oligohydramnios. If you notice the causes, so ACE inhibitors, NSAID, renal anomalies, hypertensive disorders. The common feature there is all of those disorders disrupt the kidney development in the fetus. So if you want to think of oligohydramnios as essentially a kidney problem, that's like 99% of the time what's causing it. Whereas polyhydramnios, like you said, EE, so anything that prevents swallowing is probably the most common cause of polyhydramnios. So that can be any type of atresia, esophageal, duodenal, I guess technically jejunal as well. Hirschsprung's could probably do it. Anything where there's not an exit, actually probably not Hirschsprung's, but anything that there's a disruption in the exit pathway to be able to swallow the amniotic fluid. And then diabetes, because diabetes is just a disorder of glucose, and glucose is a solute. And so solutes are going to pull water in. So the baby's going to excrete a ton of extra fluid if the mother is diabetic. Multiple gestation, because more babies need more fluid, and anencephaly is the same thing, can't swallow. So most of those are because of a can't swallow kind of thing. And then the complications, I rarely see those tested. So they're there if you want to look at them later, but I don't think they're super important. If you think about it, too much fluid, then you basically make the uterus is this big, you make it even bigger. So you can think of things related to being too large. So PPROM will happen because there's excess stress on the uterus because of the stretching. Umbilical cord prolapse, as you stretch the uterus, the cervix enlarges, you can prolapse the cord through it. Whereas oligohydramnios, if there's less fluid, you're more likely to aspirate meconium. And then if there's an enclosed space in the uterus, just like you're likely to compress the fetus, you're also likely to compress the cord. So you can have the cord compression. And speaking of that, sorry, go ahead. No, I was just going to say, I wanted to do a slide on fetal heart tracings and I didn't get around to doing it, but I figured you guys do enough of it. So I'm sure you know them well enough. It's definitely worth knowing. I think you'll probably see one of each on the shelf. So sorry, I didn't mean to interrupt you. You should say what you were going to say.
I was just gonna say trisomies. I googled it. Trisomies polyhydramnios.
Good. Add that to the list. Okay, and these are just quick shout out things and then we'll be done. So this is the other portion of the shelves will be a couple of word associations and then just pick the answer, and you almost can't do anything else but just know it. You can kind of rule stuff out. That's probably the next best way to do it, but so we'll just go through these quickly. 57-year-old, unilateral breast erythema, skin dimpling, and warmth. I kind of gave this one away already earlier. I guess this is the test if y'all were listening or not.
It's just
So
Is this one inflammatory breast carcinoma?
and it could probably be any type of carcinoma, right? But the unilateral erythema and widespread skin dimpling is usually that. And the reason being is because it invades the lymphatic ducts. And so if all of the lymph is being trapped in the breast, it usually pools and makes the breast edematous. And then the skin dimpling, I believe, is just from the hair follicles retracting. It's not from the actual nipple retracting, it's from the hair follicles. Fun fact, I guess. Okay. 52-year-old with a history of PCOS, and now she has postmenopausal bleeding for a month. Is there anything that somebody who's had PCOS for a long period of time is at risk for? Yeah, it looks like you probably know it. Yeah, sorry, I jumped the gun on that one, but yeah, endometrial cancer. Just like a quick review. So tamoxifen or estrogen things are also a risk factor. Being obese, they might throw that on there as a risk factor. There's the whole early menarche, late menopause. So exposure to more cycles of estrogen is also a risk factor. And then Lynch syndrome, so HNPCC or whatever the other names for it are, is a risk factor for endometrial cancer. It's probably worth knowing. They won't test you on a bunch of those, but it's probably worth knowing a couple of those. Okay, 28-year-old, 33-week pregnant patient, fever, right upper quadrant pain, rebound, and guarding. This one's tricky and it's vague on purpose, so you can totally shout it out and be wrong. I was wrong, I think, when I saw this question originally.
Since she's so pregnant, her appendix could have moved up, so it could be appendicitis.
Yep, that's really good. That's what I was going for, and I realize how vague that is, but the uterus just displaced the appendix higher up in the pregnancy. So it could still be a liver-related thing, right? But if you see right upper quadrant pain in a very pregnant person, don't rule out appendicitis. I think that's the goal of this, is don't just like, oh, well, it's not right lower quadrant, so I'm going to rule out appendicitis. I wouldn't say that it's guaranteed to be appendicitis, but definitely don't rule it out. And then a 9-year-old with some sort of tissue protrusion at the urethra. Kind of odd, but they like to go over it.
You mean like a imperforate tiny?
Close.
No, she's 9. I don't know.
That could be, but I think that would be a little bit in a little bit different location. That's a good one. That's actually coming up later, not to give it away.
Is this like that cancer, the grape-like mass? Is that what you're going for? The sucker or something? I don't know how to pronounce it at all.
I should have put, I could have been more, I could have worded this better. That wasn't what I was going for, but that's another good one. What I was going for on this one was urethral prolapse. So basically, I know it's weird, but it's definitely been tested. So basically the urethra is like obviously a tube that passes urine. So what happens is in older women and younger kids, if there's estrogen deficiency, which in both of those cases, they're not going through periods, right? So there's estrogen deficiency. Estrogen in general keeps, one of its purposes is to keep the whole vaginal tract lubricated and properly taut. And so if in young children and older adults or older women that are postmenopausal, you can have prolapse of the urethra. And so it'll be this vague, it sounds weird, but you're like, that it sounds like a lot of the things you guys said, but it's like, why would it be at the urethra, right? And the reason is if it's a prolapse. So you treat them both the same way. You treat it essentially like you treat menopause for vaginal atrophy. You just use topical estrogen. So, but yes, I'll answer the sarcoma botryoides or whatever, that's another good one. So that's the one that the grape-like masses protrude, but that's actually through the vagina, right? And so then what you said, EE, actually, I won't do that one yet because I think that's coming up. I don't want to ruin it, but you guys will get it immediately. Out there it is. Actually, no, that's not it. 5-year-old, I saw this on peds all the time. And I remember being like, what in the heck? 5-year-old with the purulent vaginal discharge and a mass at the vaginal introitus. The discharge might be like in a kid with a foreign body. So you can put a foreign body in your nose, in your ear. Last one on this slide. So a non-tender abdominal bulge in a postpartum patient, but there's no fascial defect. So you palpate it and the fascia is still intact. This is important. This is kind of cross covers with surgery. This is also very difficult. I'm putting these on here on purpose. And there's a reason why they test it, which I'll get to in a second.
It's just like a hernia?
Less, it's essentially, it's called rectus abdominis diastasis. It's basically just where it's essentially similar to a hernia, right? Where the tissues just kind of relax. But the difference is, so hernias, there's actual separations in the tissue. Diastasis, it's basically where the fascia bulges out from stress from the delivery. But because there's no actual fascial defect, you don't need surgery. So they could test you and say, what's the next best step? And you don't have to do, you can just manage it normally for the most part. Unless it's been months and they're like, oh, cosmetically, it's bothering me, I want something done about it, then you can do surgery. But the reason I say this is that when you guys do surgery, there's a similar thing with wound dehiscence in surgeries. So basically what they want to test is that if the fascia is intact, you don't need surgery. And if the fascia is detached in any way, so if you palpate and there's a gap between the fascia, they need to immediately go for surgery. So you can have all of the skin be detached, but until the fascia is detached, you don't need surgery. And it's the same thing for pregnant women and abdominis diastasis. So I know some of these are weird. These are less likely to be on the shelf. I put them on here. We're already at an hour. I'll skip through these. Would y'all want to review these on your own and test yourselves, or do you want me to just click through them real quick? I'll click there. You probably know them and you'll see them on peds. Okay.
Does that stuff come up a lot on the OB/GYN shelf?
Not a lot, but there might be a couple questions on it. So it's not worth spending time on unless you're doing peds. If you're doing peds, there'll be every single one of those will be on the shelf. But okay, 62-year-old, postmenopausal bleeding, thickened endometrial stripe, and an ovarian mass. What is the name of this tumor?
Granulosa.
Granulosa. Yep. It's the granny tumor, right? Except the tricky part is that it can also happen in kids, but it presents differently in kids. It presents with precocious puberty. And if you think about what estrogen does in different age groups, so estrogen in a person who's completed puberty, like a postmenopausal person, it will just cause the uterus to bleed because it just grows and grows and grows and then bleeds. Whereas estrogen in a patient, in a young kid who hasn't gone through puberty yet, will just cause them to go through puberty. So the reason the symptoms are different is just because of where they are in their life cycle. Oh man, I didn't do this is the one you said, EE, I didn't do the transition right. So amenorrhea and cyclical abdominal pain, or they can say a bulging mass, but it'll be at the vaginal introitus is how they'll say it. So the difference between that and urethral prolapse is it won't be at the urethra. But it's kind of similar. It's just a protrusion of tissue that's either in the imperforate hymen case is trapping all of the menstrual tissue, whereas urethral prolapse, it's the actual urethra. This one is tricky. This one got me for sure when I saw it. A 9-year-old female, firm, tender breast mass posterior to the nipple, but it doesn't feel like a cyst. It's just feels like a mass. It might be like tender and like, oh, this came out of nowhere and it's just been like bothering me. This one's hard. So this can actually just be normal breast development, right? So oftentimes breast development is just asymmetric for whatever reason. So it feels like a mass and you're like, that's so weird. Why does a 9-year-old female have a breast mass? And the reason it's posterior to the nipple, right, is because that's where the breast tissue develops first. So don't be tricked. If they said a 6-year-old or like a 5-year-old girl with the same thing, you'd probably start to think precocious puberty or some sort of breast mass or something. But 8, 9, 10, that's like close and closer to normal. So you'd probably be safe saying that's normal development. Your world just likes to get trickier and trickier. Man, I messed up the transitions on these. You guys already know this though. Multiple miscarriages, VDRL, and elevated PTT is antiphospholipid antibody syndrome. One thing that I always forget is that PTT is not, so you're like, why is PTT elevated and they're having like thrombotic events? And it's because PTT, it's just a lab artifact. It's not actually elevated. The lab just shows that it is. So they're actually in a hypercoagulable state, but the elevated PTT makes you think that they should be bleeding, but in reality, they just clot a lot. Okay, what about a pregnant woman with fever, dysuria, and flank pain?
Pyelonephritis.
So because it's usually pretty clear, they'll just ask you what to treat it with. And you need to hospitalize them and you need to use a cephalosporin. You can't just use like amoxicillin and we'll see you later, because once an infection has spread, so just like the reason you screen for UTI or the urinalysis in early pregnancy is just because of the risk of pyelo in pregnancy is much more than a typical person. So you need to hospitalize and you need to use a 3rd-gen cephalosporin. Okay, last slide. 10-week pregnant female, uterine size larger than dates, severe nausea and vomiting, hypertension, markedly elevated beta HCG.
Mole. One of the moles.
And typically a complete mole. So the complete moles produce HCG, so that's why that's elevated. And the reason, to my knowledge, so you can also have hyperthyroidism because beta HCG can stimulate the thyroid gland. You get the hypertension and the severe, well, the hypertension is usually because it can cause preeclampsia. So if you see preeclampsia in somebody, like clear preeclampsia symptoms, like they have really high blood pressure, protein in their urine, they're unstable, it's probably from a mole. It's probably not just from some early onset preeclampsia. And then the severe, actually, I won't talk about that yet. Let's move on. Pregnant patient with twins on ultrasound. One has dysmorphic limbs and a flattened face, and the other has polyhydramnios and polycythemia. What is that called?
Twin transfusion.
Yep. So one twin steals all the blood essentially. So one is overly fueled, the other has got too little. Funny enough, I think it's the oligo baby that has the highest likelihood of survival. So to me, that's just karma, right? The baby that steals. And then what would you call the type of pregnancy in the last scenario?
Monochorionic diamnionic.
Yep. Monodi. So the chorion basically is just the placental source essentially. So if they're sharing the placenta, that's the only way you could get the scenario. But then if the amnions need to be separate, because otherwise they could share the amniotic fluid in the amniotic sac that way, even if they would just excrete it into the same sac. So you have to have monochorionic to share the same placenta. I think there's some situations where you can have dichorionic, but I think most of the time the placenta and the chorions go together. And you need to have 2 separate sacs, otherwise the fluid would pool into the same sac, and then you would end up probably evening out in the end. Okay, pregnant woman, severe nausea, vomiting, hypotension, ketones in urine, guaranteed to be on the shelf.
Is this just hyperemesis?
Yeah. Sorry. Yeah, that's great. I was just going to give you another hint, but you got it. And then so they'll often turn it into an internal medicine shelf and ask you for secondary things. So just think vitamin deficiencies if you're vomiting, or they'll say the hyperchloremic, hypokalemic, hypochloremic metabolic alkalosis, right? Like the vomiting baby, like the pyloric stenosis. That's another way they can ask it, is they'll say, okay, so what would the lab values be? Or what vitamin, so they'll just throw in some B1 deficiency. So they'll say they're encephalopathic and their eyes are moving in weird directions. They'll just try and get you to recognize vitamin deficiencies. they like to connect it any way they can to internal medicine as best as they can. So they will try that. Anemia, thrombocytopenia, and elevated LFTs.
HELLP syndrome.
Yep. This is just an extension. I think the way we have classified it in the US is an extension of preeclampsia. So just like preeclampsia, except you can essentially think of this as already severe features, a very specific version of severe features. So you need to deliver most of the time if they give you a HELLP syndrome patient. This one may be a little bit more tricky unless you've seen the questions already. So severe right upper quadrant pain in a pregnant woman, thrombocytopenia, hypoglycemia, and DIC. It looks like the last one, but it's a little bit different. It looks worse. Their right upper quadrant pain is worse. They're profoundly hypoglycemic. They might have DIC. It looks like HELLP syndrome, but quite a bit worse. This one's trickier if you haven't seen it.
Is this the it's like acute fatty liver?
Yep.
Pregnancy.
Yep. And the reason I put it on here is because that was another thing that I could have made a differential diagnosis slide. So the way I've decided to distinguish it from HELLP syndrome is they always give you some really abnormal glucose values. So it'll be like 50s, 60s. And then they'll probably give you some lab values that suggest DIC. So beyond the thrombocytopenia, you might see elevated PT and PTT. And then in general, they seem worse off. In the questions I've seen, they seem more severe than the HELLP syndrome patients. But I think they're both severe. They both need delivery, I think, as the cure. Oh, is there another slide? Oh no, I'm sorry, I lied. Erythematous nipple rash. It's pretty much only one thing they test this on.
Paget?
Yep. The tricky thing is look out for an underlying ductal adenocarcinoma. So I think it's breast, but not vaginal, that if this is in the breast, then there's like 75% chance there's an underlying breast cancer. So you need to do some sort of further evaluation like a mammogram. So another feverish pregnant patient, but instead of the flank being tender, now it's the uterus that's tender.
Chorioamnionitis.
Yep. Chorio. So basically the best way to distinguish the fever conditions in pregnancy is what's tender, where's the pain. So if it's the flanks, that's where the kidneys are. If it's the uterus, that's what's infected. If it's the right upper or right lower quadrant, it's probably the appendix or a related organ because the uterus isn't in those locations typically. So exactly. So this is kind of like the last one, except 7-year-old now, breast development, onset of menses, elevated basal LH. So this is like not normal. The whole point of this is to be the abnormal version. So this is precocious puberty, and it's central because if it's coming from the pituitary or hypothalamus, that means it's from the brain. It's a central cause. Whereas the peripheral causes will be either from the ovary or from the adrenal glands most often. So LH and GnRH will be suppressed. Definitely worth knowing. So amenorrhea, anosmia, cleft palate, they can have a ton of other weird things as well. These are just the ones that I've seen most commonly tested. Yeah, I saw you say it, Kalman syndrome. Sorry, Carly. I actually didn't know until I was studying for this shelf that the cleft palate was a thing. So I think the GnRH bulb, the olfactory bulb, I think there's also some portions of the palate that come from this place, is my understanding. So basically anything that starts centrally can be malformed. So there can be cleft palate. There can be like, I think there's a couple other things. I won't say it just in case it's not right. This might be the last one. So 35-year-old female, hirsutism, acne, temporal balding, but it seems weird. It doesn't seem like typical PCOS because there's an ovarian mass noted, a single ovarian mass instead of bilateral.
Sertoli-related tumor.
Yeah, so it's worth it to know all of the tumors, the ovarian tumors. I just put the two that I felt like were tested a lot on step 2 and the shelf exams. Yeah, so that's actually the last slide. Sorry for lying. So